as Emily briefly mentioned, Tate is a graduate of our medical school and also the pediatric residency program, where he won the first place award for his presentation at the press meeting that year. He then went on to Cincinnati Children's Hospital to complete his neonatology fellowship, and then came home back and joined as assistant professor on the tenure track. Tate is a physician scientist interested in the impact of fetal and neonatal inflammation on the offspring health. During his fellowship, he was focused mostly on the pulmonary outcome, but since starting here at the U, his focus has been on the developing brain. A unique feature of Tate's research in that most people think of white matter injury when there is perinatal inflammation, whereas Tate has focused also on the gray matter, and currently is interested in looking at the role of microglia, the resident macrophages in the brain, which can have both pro-inflammatory as well as anti-inflammatory effect, depending upon the insult. Tate was initially supported by a K-12 grant and is currently supported on a mentored physician scientist award, what we know as the KO8 award. He's also a co-investigator on an NIH-funded program project grant looking at the immunological and neurological impact of neonatal anemia. Tate has published quite widely his research in many high-impact journals, and his paper last year in pediatric research was awarded the Best Basic Science paper at the recent Julie Ross recognition event. Today, Tate is going to tell us about fetal inflammation and the developing brain. Tate?
Thanks so much for inviting me to present Grand Rounds today. I have no conflicts to disclose. As an introduction, I'm going to start with this case. It begins with the baby's mother, who had a cerclage placed at 16 weeks due to cervical insufficiency that had resulted in a previous pregnancy loss. All was well for about 7 weeks until the mother presented due to a rupture of membranes and contractions at 23 and 2 weeks. She was treated with a pretty standard regimen of antenatal steroids, tocolysis, and antibiotics. She had tested positive for group B strep. After a few days, though, she developed fundal tenderness and fetal tachycardia, so the cerclage was removed, where they noted a purulent discharge from the cervix. She was diagnosed with III, which stands for intrauterine infection or inflammation or both, or what has commonly been known as chorioamnionitis. Of course, she then progressed and her premature baby was born at 23 and 5 weeks in our NICU. The baby was intubated at birth and received surfactant. Fortunately, from a ventilator standpoint, she did quite well. Her oxygen needs in ventilator settings were very low, such that she was even extubated earlier than usual, although just briefly. Due to the prolonged rupture and apparent intrauterine infection, the baby was also treated with antibiotics. What stood out for her, though, was her white cell count, which was 54,000 at 24 hours and 72,000 at 48 hours. Despite these severely elevated cell counts, her bacterial cultures remained negative. Unfortunately, there was no pathology available, but her leukocytosis most likely represents a profound inflammatory, but probably non-infectious reaction to her mother's infection. Today's talk is about how this type of inflammatory response affects her brain development. I have 3 main objectives today. First is for everyone to better understand fetal inflammation and its effect on preterm infant neurodevelopment. Second, to become more familiar with the pathophysiology of fetal inflammation and its effect on neurocellular injury. Third, we'll discuss ways that neurodevelopmental outcomes worsened by fetal inflammation could be improved. So the mother in our case, as I mentioned, was diagnosed with III, and which stands for intrauterine infection, inflammation, or both. The name was recently suggested to be changed to III by an NICHD panel for several reasons, but mainly because the term chorioamnionitis was not consistently used and is really a misnomer, suggesting infection of fetal membranes when the disease process itself is much more varied, as we'll see. So now that I've said that, today I'm mostly going to call the disease chorioamnionitis because nearly every study I reference refers to it that way. III refers to the clinical syndrome of pregnancy that the NICHD defined as a maternal fever plus an elevated maternal white blood cell count, purulent fluid, or fetal tachycardia. Uterine tenderness or maternal tachycardia are also common signs. This constellation of signs and symptoms has often been referred to as a clinical chorioamnionitis. Histologic chorioamnionitis is based on pathology diagnosis where an infiltration of neutrophils is seen in the chorionic plate and amniotic membranes, where it's considered maternal inflammation, or in the chorionic vessels and umbilical cord where it is considered a fetal inflammation. Histologic findings, especially maternal inflammation, are frequently present before there are signs of a clinical chorioamnionitis, suggesting that clinical chorioamnionitis is a more advanced disease. This is how chorioamnionitis looks histologically. On the left is a normal membrane with a thin amniotic epithelium towards the upper left, which surrounds the fetus, and the chorion above the decidua. Picture on the right is an example of chorioamnionitis, and you can see the significant infiltration of neutrophils at the chorion and the thickening of connective tissue and infiltrate in the amnion. Compare this to the absolute lack of inflammatory cells in a normal membrane. So how common is chorioamnionitis in preterm deliveries? Well, this study of 4,000 preterm infants measured the incidence of histologic chorioamnionitis at each gestational age. It's important for a couple reasons. First, we see that histologic chorioamnionitis is extremely common, especially in the very preterm group, less than 28 weeks, where around 60% of preterms are affected, making it the most common cause of preterm birth at these gestational ages. Second, chorioamnionitis decreases as a percentage of births as gestational age increases. Other causes of preterm birth, such as preeclampsia, become more frequent. Keep in mind that this is a percentage and not absolute numbers. Even in these late preterm infants, so chorioamnionitis is present in 20 to 25% of births. Despite how frequently we find histologic chorioamnionitis in the very preterm infants, few of these infants result with positive blood cultures. This study from the NICHD Neonatal Network reported only 2% of nearly 8,000 infants with a birth weight between 400 and 1,500 grams had a positive blood culture within 72 hours of birth. Of those positive cultures, the most common were organisms that we typically think of as pathogenic, such as Group B strep and E. coli. So given this data, there's a significant gap between the number of preterm infants exposed to chorioamnionitis and the number with a culture-proven infection. It's possible, though, there are infections in preterm infants that go undetected. For example, Rheoplasma species are by far the most common amniotic fluid isolates in this study of 99 women with both preterm rupture of membranes and positive amniotic fluid culture. And in many cases, ureaplasma is also detected in infants. This randomized trial of preterms less than 29 weeks that required positive pressure ventilation found that about a third tested positive for ureaplasma, either by culture or PCR in the first 3 days of life. So ureaplasma is likely to be common in preterms, despite standard blood cultures that are typically negative. But it's still unclear whether testing infants for ureaplasma is helpful. And we'll talk a little bit more about this later. So many of these infants exposed to maternal inflammation and infection, many of these infants are exposed, but the majority of which do not have a culture-proven sepsis, but they develop the systemic fetal inflammatory response syndrome, like the infant in our case. It was originally described in pregnancies complicated by a preterm labor or a preterm premature rupture of membranes, where there was an elevated fetal plasma level of IL-6, which is a common inflammatory cytokine. Elevated plasma cytokines illustrate the systemic neonatal response to the infection. Histologically, fetal inflammation is identified when fetal placental vessels or umbilical cord are infiltrated by leukocytes. More importantly, though, fetal inflammation is associated with higher rates of severe short and long-term morbidity and death. And fetal inflammation affects a large number of preterm infants, somewhere between 30 to 40%, depending on how the populations are measured, whether the definition includes all preterms or just the earliest, and whether it's measured by pathology or IL-6 levels. Funicitis is a name for umbilical cord inflammation and a histologic sign of the fetal inflammatory response. The severity of funicitis is staged by where the infiltration is found, and then it's graded by the number of infiltrating cells. Umbilical vein infiltration defines the first stage, and umbilical artery infiltration defines stage 2. Infiltration of cells into the Wharton's jelly in a ring around the cord vessels, as seen in these pictures, defines stage 3. And we'll see this classification used in some of the studies in the coming slides. So how are pathogens able to infect this protected space? Pathogens typically ascends from the lower genital tract where it resides as normal flora, enters the uterine cavity, and then tracks along the chorionic and decidual space. Infections can also result from a hematogenous spread from the mother. On the left here is a magnified view of the layers of membrane tissue away from the placenta. And you can see how there are these potential spaces between tissue layers for microbes to track and then instigate an immune response, or what we see as the leukocyte infiltration in histologic chorioamnionitis. The inflammation can progress by placental cells producing cytokines that enter the amniotic fluid, where they can affect the fetus by contact with skin and umbilical cord, and by ingestion through breathing and swallowing, which then instigate the fetal systemic cytokine response. In some pregnancies, the pathogens pass through the chorionic membrane, infecting the amniotic fluid, or the membrane's rupture, leaving a more direct path. In some cases, the infant is also infected. So how does the fetal inflammation affect preterm neurodevelopment? Well, chorioamnionitis is a risk factor for long-term brain injury in term and preterm infants. These are data from a meta-analysis that includes infants of all gestational ages. They showed an increased risk for cerebral palsy and periventricular leukomalacia when either clinical chorioamnionitis or histologic chorioamnionitis are present. Risks from clinical chorioamnionitis are a little bit greater than the histologic chorioamnionitis, consistent with it being a more advanced disease. But the outcomes in this study are pretty similar between the two. This study compares neurodevelopmental outcomes based on histologic chorioamnionitis exposure of approximately 400 preterm infants born less than 29 weeks. In this population, histologic chorioamnionitis increases the adjusted odds of cerebral palsy in the exposed infants by 2.5 times compared to the non-exposed preterms. Compared to the prior study that suggests that histologic chorioamnionitis is a more significant risk for preterm infants than full-term infants. This is a more recent and larger study of over 1,000 infants. The infants are slightly older, including preterms 24 to 32 weeks, using the European EPIPAGE database. Here they found increased odds of CP, but not death when infants were exposed to clinical chorioamnionitis alone, which is shown on the top row with an adjusted odds ratio of 2.1, or exposed to both clinical and histologic chorioamnionitis, which is shown on this bottom row, where the odds ratio is 3.2. In this population, they did not find a significant association between CP and histologic chorioamnionitis alone, demonstrating some inconsistency between the studies. In the older population, this study may affect this outcome. Looking at other neurodevelopmental outcomes, in this smaller study of a similar population of preterms 24 to 32 weeks, motor and cognitive scores were assessed at 18 to 24 months based on presence of histologic chorioamnionitis. In this population, exposed infants have lower cognitive scores as measured on the Bayley-3, but motor scores are not different. So this is a large study of infants less than 27 weeks from the Neonatal Network, and we're starting to look at how the severity of exposure affects long-term neurodevelopmental outcomes, measured in this study between 18 and 22 months. The assumption is that once the mother or fetus has signs or symptoms which define clinical chorioamnionitis, the inflammation has become more advanced, and studies mostly bear this out. Here's a comparison of infants exposed to histologic chorioamnionitis alone and infants exposed to both histologic and clinical chorioamnionitis to those without either exposure. Important outcomes of this study are a higher percentage of infants with histologic and clinical chorioamnionitis exposure having cognitive scores less than 70, which is a significant difference between the infants with just one or no exposure. There's also a significantly worse neurodevelopmental impairment with both exposures. Interestingly, there's a mortality benefit if there is histologic chorioamnionitis alone compared to no exposure, which is likely a statement about the other non-chorioamnionitis causes of preterm birth and their effect on mortality. But the benefit is lost as inflammation becomes more severe. There's a similar benefit for the histologic only group when comparing the composite outcome of death and neurodevelopmental impairment to the non-chorioamnionitis group. But again, the benefit is lost as inflammation worsens. When gestational age is included in the multivariable model, histologic plus clinical chorioamnionitis compared to no chorioamnionitis is still associated with increased risk of poor cognitive scores less than 70 and lower total scores. There also continues to be a benefit in mortality in the group exposed to histologic chorioamnionitis compared to no exposure, which I think highlights the risk for these other infants born preterm, which are mostly due to maternal medical indications. Here we're looking at how fetal inflammation, in this case measured by funicitis, affects outcomes. We previously looked at this study of infants in less than 29 weeks, but here they separated the infants with funicitis from those with histologic chorioamnionitis alone. And we can see that the primary drivers of the cerebral palsy outcome are the infants with fetal rather than maternal inflammation. Worsening fetal inflammation, defined by funicitis staging, also appears to worsen outcomes. In this study of 350 preterm infants between 23 and 28 weeks, exposure to histologic chorioamnionitis was separated from groups with an increasing severity of funicitis to compare neurodevelopment and death outcomes. In contrast to what we saw earlier in the study, histologic chorioamnionitis increases risk of death and the combined outcome of death or neurodevelopmental impairment. Across studies, there are inconsistent outcomes when comparing histologic chorioamnionitis to no chorioamnionitis, and the differences are likely dependent upon the gestational ages within cohorts and which babies are included in the reference groups. What's more consistent is that as the severity of inflammation increases, the likelihood of poor outcomes increases. And in this study, the most severe inflammation is described as necrotizing funicitis, and the relative risks of death and neurodevelopmental impairment measured independently are increased by 2 to 2.5 fold compared to references, which are other preterm infants. So we're talking about a 2.5 times increased relative risk from an already high risk starting point. Looking more specifically at different long-term neurodevelopmental outcomes, CP, autism spectrum, cognitive impairment, and epilepsy, a worsening stage and grade of both maternal and fetal inflammation are associated with worse outcomes at 10 years of age. These are infants enrolled through the ELGAN study of preterms, less than 28 weeks. And the adjusted odds ratio on multivariable analysis is significantly increased at a higher stage and grade for CP, autism, and epilepsy based on this outcome frequency data, again suggesting worse outcomes with worse inflammation. There also appears to be a small benefit with lower odds of cerebral palsy associated with a less severe stage of maternal inflammation, similar to what we just previously discussed. There have also been several studies that haven't detected differences in long-term outcomes based on the presence of chorioamnionitis, including, importantly, here at 18 years of age. And the studies I listed here of older gestational age infants without any differentiation of severity of inflammation. So to summarize so far, it's pretty clear in the literature, I think, that the worst outcomes occur when more severe inflammation occurs in the younger gestational infants. Unfortunately, inflammation is the primary reason these earliest infants are born. So what's occurring in the brain at this time to make premature infants susceptible to brain injury? From the time most premature infants arrive in our NICU, rapid brain development is occurring. Myelin is forming. Billions of neuronal connections are being perfected. Precise folding of gyri is occurring. And the weight of the brain triples during the last 12 weeks of gestation. But the brain during this development is particularly vulnerable to adverse conditions. And inflammation is one that likely interferes with many of these processes. So how does systemic inflammation affect the brain? As we discussed earlier, circulating IL-6 is one definition of the fetal inflammatory response. Most importantly, though, it's a sign of the systemic inflammatory process going on in the baby, and one of several cytokines that are likely elevated, along with other markers like CRP or white blood cells, as we saw in the example case. The brain is affected as these circulating neonatal cytokines pass through the blood-brain barrier or stimulate receptors on the brain epithelium, which then initiate an inflammatory cascade in the brain. And these reactions have a significant effect on several types of brain cells. White matter injury is the classic insult caused by fetal inflammation. Oligodendrocytes are the brain cells that produce myelin. The immature oligodendrocytes, which are known as pre-oligodendrocytes, are predominant at the beginning of the third trimester and susceptible to injury from cytokines, reactive oxygen species, and excitotoxicity. All these are components of the inflammatory response. When the cells are injured during this stage, they're unable to adequately perform their functions as the brain develops, and thus we see a white matter injury. We can see these changes occur in the white matter preterm infants following chorioamnionitis by using less invasive methods. This study of preterms less than 33 weeks used an MRI at term-corrected age to measure fractional anisotropy in the white matter tracts. The yellow color is the average FA in white matter tracts in the controls. The voxels shown in blue represent areas of decreased FA, which are found in the chorioamnionitis exposed preterms compared to the unexposed. Affected white matter tracts include corpus callosum, anterior and posterior limbs of the internal capsule, the external capsule, and cerebellum. This suggests one mechanism for long-term impairments occurring in these infants. This is a model summarizing the pathophysiology of white matter injury. What starts as chorioamnionitis advances to fetal inflammation, generating cytokines and inflammatory cells, which trigger a response in the brain that is typically mediated by microglia, which are the resident macrophages of the brain. Injury to immature oligodendrocytes via excitotoxicity, reactive oxygen species, and cytokines result in this white matter injury, which can ultimately be seen clinically with cerebral palsy, cognitive deficits, autism, and schizophrenia. Obviously, we can't look at cells in babies' brains, but we can use animal models to figure out how these injuries occur and potentially find ways to prevent or fix the problem. This is a mouse model of fetal inflammation initiated by using an injection of lipopolysaccharide, or LPS. LPS is the gram-negative bacterial molecule commonly used to stimulate inflammatory response and is the driver of sepsis during an E. coli infection. When injected into pregnant mice or other animals, there's a response in the fetus without disrupting the pregnancy. Importantly, newborn rodent brains are developmentally equivalent to a 24 or 25-week premature infant, so they provide a useful comparison. In this study here, at 14 days of age, oligodendrocytes, which are stained here in brown, were measured in the cerebral cortex and hippocampus. You can see the significantly decreased staining after LPS treatment, showing fewer oligodendrocytes present in the two bottom pictures compared to the controls, which are on the top row. You can especially see here where the red arrows are pointing. Fewer cells mean lesser function. And this study is looking at myelin protein in the subcortical white matter in a preterm sheep model of fetal inflammation. And you can see the 50% decrease in myelination 14 days after LPS in the picture on the right side. And a 50% decrease in myelination would likely cause noticeable impairment, as consistent with what we see occurring in some preterm infants. So I mentioned microglia. During brain development, particularly during the third trimester, microglia are involved in normal developmental activities, such as synaptogenesis, where they help the brain form the proper connections. However, another function is in innate immunity, where they activate in response to inflammatory signaling, which is observable by a change in their morphology to a thicker cell body and shorter processes, as seen in these photos. When this occurs, they take on immune functions such as producing nitric oxide and cytokines and presenting antigen, all primarily in an effort to fight an infection. However, there usually is no infection in the brain, especially, only a dysregulated inflammation, and in the process, vulnerable brain cells in the gray and white matter are injured. Microglial activation has been consistently shown in preclinical models of fetal inflammation, including sheep, rhesus macaque, and rodents in these three examples. Here, IBA1 and CD11B are used as markers for microglia, and you can see this predictable morphology change occurs in each of these studies after LPS exposure, signaling the microglial activation. While white matter is more commonly known, as Regu alluded to earlier, and maybe partly because white matter injuries are more easily seen on ultrasound, neuronal structure and function are also affected. However, they have been less frequently studied in this context. To assess how fetal inflammation affects neurons, these experiments also used a rodent model, injecting LPS at 2 different prenatal times, and then shortly after cultured the neurons from the affected brains. The LPS exposure results in this abnormal morphology in the neurons, which can be seen in the bottom picture by this interrupted dotted line appearance of dendrites, compared to an uninterrupted dotted line in the controls in the top picture. In the graph on the right side, they quantified injury and found that there were fewer branching dendritic processes at both of the chosen time points after exposure to LPS. Changes in neuronal structure can also be seen on a more macro level. Here, MRI studies show that the hippocampus, which is a primarily gray matter structure, is decreased in volume in 14-day-old rodent pups that were exposed prenatally to LPS. The changes here occur equally between males and females. The hippocampus is important functionally for learning and memory. And as we showed in the outcome studies, poor cognition is a primary impairment resulting from fetal inflammation, therefore making the hippocampus a likely area of injury in the brain. For this reason, we have also been interested in how fetal inflammation affects the hippocampus. Specifically here, we studied glutamate receptors, which play an important role in synaptogenesis and synaptic plasticity in neurons. Excess glutamate receptor stimulation can cause neuronal excitotoxicity and subsequent cell injury. In our rodent model, we found an upregulation of these receptor subunit genes on the left, which correlate to higher phosphorylated protein expression of NMDA receptors, which are shown on the right. Phosphorylation of glutamate receptors alters the biophysical properties of these channels. And so dysregulated glutamate receptors following fetal inflammation is another possible mechanism by which inflammation may worsen neurodevelopment. We further explored the effects of fetal inflammation on hippocampal transcriptome. We used RNA-seq techniques to study the hippocampus at 7 days of age following fetal inflammation, and found there were around 700 genes that were differentially expressed following prenatal LPS, which accounts for 4% of the sequence transcriptome. Of these genes, around 500 were downregulated, while about 200 were upregulated. The analysis of these differentially expressed genes was performed using an ingenuity pathway analysis, which determines how these gene changes affect pathways and biologic functions. On the left are several canonical pathways that are important for normal neurodevelopment, but on our model, they are predicted to be downregulated by fetal inflammation. The black color represents a z-score of at least -1.5 and thus downregulation. The p-value calculation is on the y-axis. On the right is a network of several dysregulated genes, the majority of which are downregulated, which is represented by the green color. Their downregulation contributes to the prediction that the critical neuronal functions that are listed in blue, synaptic plasticity, long-term potentiation, and synaptic transmission, are all inhibited by fetal inflammation. Similarly, in this network, the important hippocampal functions of learning, cognition, and memory are also all predicted to be inhibited based on these genes downregulated by these early inflammatory insults. Long-term cognition appears to be affected by fetal inflammation when learning and memory behaviors are tested in the same model at adult ages. This is a Y maze. Here we're measuring working memory by testing spontaneous alternation. Subjects with normal learning and memory more often explore in this predictable pattern, which is shown on the left, where they explore each arm in 3 successive entries. After being placed in the middle, rodents will explore one arm, and then followed by the second. They then have an equal opportunity to explore the third arm, which would be correct, or return to the previous, which is incorrect. And in this case, we found that rodents exposed to fetal inflammation less frequently explored in the correct pattern, essentially scoring at 50% or chance, indicating a problem with their working memory. Okay, so far I've shown that neonatal outcomes worsen as inflammation worsens in preterm infants. And we've also discussed how fetal inflammation affects brain cells and mechanisms by which these outcomes likely occur. But now the question is, can we do anything about it? I think it's pretty clear that fetal inflammation is a disease with long-term implications. We have methods to diagnose it pretty accurately and timely. But is there any treatment, and can we identify those patients that would benefit? It's possible that we already do something about it. This table is from the Neonatal Network study showing how antenatal steroids affect mortality and severe neurodevelopmental impairment in premature infants 22 to 25 weeks. We know about the profound effects of antenatal steroids, but even for infants exposed to chorioamnionitis, the effect is major. Decreasing mortality and impairment by about 1/3. In fact, there was slightly less mortality or impairment in the chorioamnionitis group receiving antenatal steroids than the non-chorioamnionitis group receiving steroids, although it's probably not a significant difference. It is possible, though, that these infants' inflammatory disease is being treated a little bit more directly. And keep in mind, this is all chorioamnionitis. We don't know how these results would look in the specific fetal inflammation group. A possible neurodevelopmental effect of antenatal steroids is their prevention of inflammatory injury in the brain. We can see the effect in this sheep model where betamethasone was given prior to LPS injection. On the top row, the increase in microglial activation caused by LPS, shown in the middle picture, was prevented by betamethasone, which is shown in the picture on the right. In the middle row, the synaptic protein synaptophysin is decreased by LPS, shown in the middle picture, but also prevented by betamethasone, shown on the right. On the bottom, similar trends are seen with myelin, but not here, shown to be significantly different. If there is treatment beyond antenatal steroids that may be beneficial for inflammatory disease, it'd be helpful to find these babies early. Pathology reports diagnosing chorioamnionitis and funicitis likely take too long to be useful for diagnosis. Biomarkers, especially in cord blood, would be a better option. We already make cord blood measurements for cord gases, blood types, and cultures. As I mentioned, the fetal inflammatory response syndrome was defined based on increased umbilical cord plasma IL-6 levels. Measuring that in babies is one potential approach, but maybe a less commonly available assay. CRP is comparable to IL-6 and has better specificity for diagnosing amniotic fluid infection, neonatal sepsis, and phenocitis, although the sensitivity is not very good. But if we're interested in targeting the most inflamed babies, we might be successful, as you can see, this large increase in CRP when phenocitis reaches more advanced stages. I added the red line to denote the lower limit of detection that's reported in our lab. These are babies with the worst neurodevelopmental outcomes and potentially those that would benefit from intervention, which is probably between 5 and 20% of our smallest preterms. Several researchers have shown in animal models that inhibiting inflammatory pathways improves brain injury. Here, decreased fractional anisotropy and increased microglial activation, resulting in a chorioamnionitis model, are both prevented when the chemokine receptor CXCR2 is inhibited. Similarly, decreased myelination, which is shown in the pictures on the left, and increased microglial activation, which are shown on the right, both in the middle row, are prevented by a TNF-alpha inhibitor shown in the bottom row pictures. I'm not suggesting that we should give TNF-alpha inhibitors to preterms, but I just share these studies to suggest that these are the pathways that are dysregulated in preterms that ultimately cause injury. Erythropoietin has been more commonly studied recently and is often given in NICUs. In this study, lambs exposed to LPS show a similar prevention of microglial activation and poor myelination after they were treated with erythropoietin. Erythropoietin appears to have anti-inflammatory properties, and there's a lot of hope based on many preclinical studies and small clinical trials that treating preterms with erythropoietin would improve neurodevelopmental outcomes. However, the PEANUT study that we were part of did not show neurodevelopmental or mortality benefit for the infants receiving erythropoietin. However, a recent follow-up study showed that babies receiving higher iron dosing while being treated with erythropoietin had better cognitive outcomes. And this is part of the PEANUT study babies. So taking this into account, erythropoietin likely needs further evaluation as a treatment to prevent brain injury on top of its use to prevent anemia and transfusions. Stem cell therapy to prevent brain injury is becoming more commonly studied, certainly in attempting to improve outcomes following neonatal encephalopathy. In this study, lambs exposed to prenatal LPS were treated with umbilical cord mononuclear cells. Similar to other studies we've looked at, this group found that the decreased numbers of oligodendrocytes and the decreased myelination in 2 different white matter regions, which were caused by LPS, were then improved by the umbilical cord cell therapy. Similarly, another group derived exosomes, which are basically cell fragments from human Wharton's jelly mesenchymal cells, and gave them to neonatal mice following inflammatory brain injury caused by LPS and hypoxic ischemia. The resulting increased microglial activation in the corpus callosum, which is shown in the middle pictures, was prevented by an intranasal administration of the exosomes, shown in the pictures on the right. A more localized steroid therapy may be a viable anti-inflammatory option. This group in St. Louis has been studying administration of endotracheal budesonide with surfactant. These experiments were in a preterm lamb model of fetal inflammation. After delivery, the lambs were intubated and given surfactant and budesonide together. 4 hours later, the tissue was collected. On the graphs here, you can see the significant cytokine reaction in the lungs and liver caused by LPS. Budesonide dampened the inflammation in the lung, which makes sense, but it also had effects systemically, similarly dampening inflammation in the liver, even after only 4 hours. Interestingly, there may also be effects in the brain. At least in the cortical tissue, LPS caused an increase in the chemokine MCP1 that was attenuated by budesonide. This group has also studied budesonide treatment clinically, administering a surfactant steroid mixture to preterm infants. They recently showed in their patient population a decrease in the severity of BPD and mechanical ventilation use compared to infants during the years before they started using the treatment. There were no differences found in neurodevelopmental outcomes at 2 years of age between the two cohorts, which is important to note that the therapy does not appear to cause harm. It may not be the answer in improving neurodevelopmental outcomes for these babies, but I partly mention it as an example of ideas that are currently being used around the country. But in this case, they aren't only implementing a practice change, they're also studying their outcomes. We talked earlier about how common ureaplasma is in preterm infants. The goal of this randomized control study was to determine azithromycin's effectiveness in clearing ureaplasma from the airway. And they found that it's pretty effective, achieving clearance in 84% of the 19 positive patients receiving therapy versus just 12% that spontaneously resolved. Again, the question seems to be whether clearance matters. They found no differences in survival or BPD after azithromycin treatment, although this study has small numbers. But it is important to note that ureaplasma is associated with adverse outcomes. Ureaplasma positive babies that required intubation, which are those that had a positive tracheal aspirate, had worse survival and BPD rates and the longest durations of supplemental oxygen and hospitalization. There are a limited number of studies of ureaplasma's effect on the brain, but the few studies show impaired long-term development in line with outcomes resulting from chorioamnionitis and fetal inflammation, which makes sense considering that much of this disease is driven by ureaplasma. A lack of improved outcomes despite elimination of the ureaplasma infection suggests that these interventions may be either too late or that the inflammatory response to ureaplasma is the real problem, and we don't address that. Changing the focus a little bit, but probably having no less of an impact. Disparities in health are another possible cause behind the worst neurodevelopmental outcomes following fetal inflammation. Chorioamnionitis and phenocitis disproportionately affect Black and African American women and infants. This is a consistent finding in fetal inflammation studies conducted in the US that provide this data, including several that I've referenced so far. For example, in this neonatal network study, Black mothers make up 35% of the no chorioamnionitis population, but 43% of the histologic plus clinical chorioamnionitis group. There's a similar trend in this population of the safe labor study, where Black mothers make up 23% of the no chorioamnionitis population, but 30% of the chorioamnionitis population. Here, Latina mothers were also disproportionately affected. We found the same result in our study in Cincinnati following during my fellowship, where African Americans make up 23% of the infants in the no chorio group, but 51% of the chorio with phenocitis group. So if we can improve disparities on the maternal side, we may be able to reduce the frequency or severity of fetal inflammation. Improving postnatal health disparities for infants of color may improve the neurodevelopmental outcomes in babies affected by fetal inflammation. So when studying fetal inflammation, there are several confounders that can confuse the interpretation of results. Gestational age is one such confounder. Because fetal inflammation is a disproportionate cause of birth for the earliest preterm infants, a sample of any group of preterm infants will be skewed younger in the fetal inflammation group, even if you're only looking at infants less than 28 weeks. So any poor outcomes may have to do more with lower gestational age than inflammation. So it's important, especially in fetal inflammation studies, to correct for gestational age for a more accurate assessment. And the human studies we looked at have done that. As I touched on earlier, We don't have normal preterms to compare to. The non-chorio babies are born for some other bad reason, usually maternal complications that necessitate delivery. Oftentimes, these babies are growth restricted, and these physiologic changes have consequences of their own that likely cause poor outcomes. So to find worse outcomes for babies with fetal inflammation, even when comparing to babies that have bad outcomes for another reason, I think that speaks to the opportunity for improvements to try to improve outcomes, not to match non-chorio babies, but match outcomes of the theoretical normal preterm baby. Intraventricular hemorrhage is another confounder in understanding the role of fetal inflammation in neurodevelopment. In most studies, intraventricular hemorrhage occurs more frequently with fetal inflammation and chorioamnionitis, including higher grade IVH. That's the case in all three of these studies here that I've already shown. In this group of preterms less than 33 weeks, there is over twice as many cases of severe IVH. In a cohort less than 29 weeks, there is more total IVH and severe IVH, which is nearly an identical finding to the first study. And in a cohort of infants less than 27 weeks, there is more frequent severe IVH in the histologic plus clinical chorioamnionitis group, again suggesting more severe inflammation is more consequential. It's not clear how fetal inflammation affects IVH, whether there's an indirect relationship as a consequence of sepsis, or some other direct effect of inflammatory cells or cytokines. Regardless, what we know about neurologic outcomes from inflammation may be a result of IVH, or IVH outcomes may result from inflammation. And this was a consequence for our infant from the case. She developed this right-sided intraparenchymal hemorrhage and dilated ventricles. But fortunately, she did not require any intervention for her hydrocephalus. So I want to mention some unanswered questions and areas needing further research and thought. It's unclear why chorioamnionitis occurs when it does. It's also unclear how or why there's advancement to more severe fetal inflammation. Is it just a matter of timing when the baby delivers during the inflammatory process? Is the type of infection important? Do more pathogenic bacteria cause more severe inflammation? How important are genetics in the development of chorioamnionitis in the first place, or in limiting or not limiting advancement of inflammation, or the fetal response or over-response and dysregulation of the immune system? All of these things likely influence the outcomes of fetal inflammation. Treatment of inflammation may be just as or more important than treatment of infection. Like I said, we are often treating an infection that doesn't exist in the baby without any treatment for the dysregulated immune response that's occurring, such as a white cell count of 70,000. Adding budesonide to surfactant is a type of treatment that may be more common in the future, but we need a lot more research to determine what's safe and effective. A lot of these concepts not only apply to fetal inflammation, but other inflammatory diseases of preterm, such as NEC or sepsis, that also cause brain injury. They may also benefit from anti-inflammatory treatment. What sets fetal inflammation apart, however, is that it's the first exposure, so it happens earlier. And the earlier in development the insult occurs, the more likely an adverse effect. So in summary, fetal inflammation is common among preterm infants. As the severity of inflammation worsens, the risk for poor long-term neurodevelopmental outcomes increases. Poor outcomes occur as a result of dysregulated inflammatory responses that ultimately injure brain cells during vulnerable periods. In animal models, inhibition of inflammatory pathways improves cellular injury. Some of the benefits of our current therapies, such as antenatal steroids, may be due to this effect. Further study of more targeted therapy based on biomarkers or other diagnostics is greatly needed, not only for fetal inflammation, but many of the other disease states that we struggle to treat. So thank you very much.
Thank you, Tate, for that wonderful presentation. Are there any questions? I see there is a...
Go ahead.
Sorry, Emily, you want me to moderate or you are
Sure,
going to
go ahead.
There is a question from Troy asking, the sterile immune response is interesting. Has anyone looked at the HLA disparity between mother and fetus that exists?
That's a good question. Not that I know of. I think, I mean, certainly that's, I mean, part of what I was mentioning when I'm talking about the effect of genetics and how many different genes that may be involved in, you know, the advancement of the infection in the mother and how it's, you know, the inflammatory process then transferred to the fetus and the neonate. But I'm not sure about HLA types, but it's, you know, it certainly makes sense that HLA is one of those genes that probably makes a difference.
So as we are waiting for others to put their questions, I have a question, or maybe at least you can comment on. You know, many of our babies are not only exposed to infection, inflammation in the fetal life, but also in the neonatal period. In other words, they can have more than one inflammatory, you know, more than one inflammatory insult, so to speak. Do you see more of an effect in that situation, less of an effect, or same?
Yeah, I think we've done some animal studies in our lab that have looked at that, and we find some kind of mixed effects. I think inflammatory insults affect inflammatory cells, such their ability to respond changes, which would lead us to think that, oh, maybe we're less affected by a second result if we've already been affected by a first. But we've also done some behavioral studies and some more long-term studies that maybe suggest that these effects actually add up, that despite less of an effect in the inflammatory cells, that maybe they're not really less of an effect. They're maybe just more efficient in producing injurious cytokines, for instance, and then eventually add up to cause more of a profound injury later. So I think we're not totally sure, but I think, as most of us might think, more injuries cause more harm, which makes sense, is probably what happens.
Other questions or
I
comments?
have a question. I always am thinking about the patients that I care for, which are the graduates of your NICU, but also in the newborn nursery, we're doing a lot more, you know, these sort of like, whatever we call them, rule out chorio, where they sort of get antibiotics, but are mostly managed in the newborn nursery. And, you know, perhaps there was some mild inflammation going on. Those older brains seem like they're at less risk, but I'm just curious if people are looking at that sort of a mild maybe chorio in an older baby. What does that look like down the road? Is anybody looking for those impacts?
Yep, for sure. I think the babies that are more severely affected are the ones who end up ill at birth. I think some of the studies the first study I compared chorioamnionitis with PVL and cerebral palsy, you know, showed with clinical chorioamnionitis increased risk of CP, and that include term babies. But I think while there's probably an increased risk of long-term issues, I think it's pretty minimal for a healthy baby in the newborn nursery. I think the ones that are at risk are the ones who end up in the NICU that are more affected by you know, what occurs in labor and stresses that occur in labor that, you know, have trouble breathing and end up with us in the NICU are the ones who have a more of a risk. And I think while there may be some longer term effects in babies like that are exposed to chorio in these term babies, I think it's, you know, it's a low risk that's probably hard to measure. But it might be, a lot of these inflammatory diseases are thought to be, a risk factor for longer term problems, such as mental illness, like schizophrenia or autism. So they may be just, the first hit in what requires a multi hits to trigger a disease. Babies who are genetically susceptible to diseases such as autism or schizophrenia, and chorioamnionitis at delivery is another hit that might add to their risk, I should say.
There is one more question from Asha asking, do antenatal steroids worsen inflammatory response in chorioamnionitis?
I would think, based on the NeoNetwork study that I showed, they're, they have, a pretty significant improvement in morbidity and neurodevelopmental outcomes. I think the studies in animals suggest that it's improves, their inflammatory outcomes in the brain. And honestly, we don't see, antenatal steroids helping every baby. And I do wonder sometimes whether the ones that are actually being helped are the ones that actually have inflammatory disease, and the ones that aren't being helped as much are the ones that don't. But I don't really know. That's just sort of a thought. But it certainly seems safe and reasonable that antenatal steroids help babies who have an inflammatory disease.
I think there is a question from Cheryl, which is an extension of similar ideas. We are, you're talking about antenatal steroid. What about postnatal steroid that we use? Mm-hmm. Are they going to have an impact?
It's a good question. I think the question is sometimes about timing, whether kind of like I showed the data with the azithromycin treatment, whether we, perhaps the most effective treatment would be preventing inflammatory injury before it happened. Question is it by the time the baby is exposed and comes out, is a steroid treatment then going to be helpful, or is it too late? I don't think we really know the answer to that, but I do think that needs to be studied. I think it's a reasonable thought to try and figure out if that helps, honestly.
All right, I don't see any other. There is one more question. Are there mechanisms to explain the apparent differences in steroid effect in neurodevelopment, specifically asking dexamethasone versus hydrocortisone?
Oh, I don't know that we really know that. I think we certainly, and we're not really sure what any of the steroids do in the brain. It's pretty clear in animal studies that it affects brain inflammation, dampens brain inflammation, but how each of them work, I don't know that we really know. Certainly not, I don't know that anybody's studied differences between dexamethasone and hydrocortisone, but I'm not sure.
I don't see any other question. I think we are.
Yes, we are at time.
So, all right, Emily, any concluding remarks?
No, that was excellent. I learned a lot as always. That's my favorite part of Grand Rounds, learning from all of my smart colleagues. So thank you for teaching me and our audience. I hope everybody has a wonderful Wednesday. Don't forget to tune in every Wednesday morning at 7:30, but especially on May 4th for our Gold-Headed Cane Awards. Have a great day, everyone.
Thanks.